Welcome to live Q&A with the experts of Rome Foundation. My name is Tanya Murphy, Rome Foundation's Executive Director. Today's session is titled Treatment of IBS-C, and I'm your host, again, Tanya Murphy, Executive Director with over 20 years of nonprofits. Really excited to be here with you today. I'd like to introduce my co-host, Dr. Douglas Drossman. Dr. Drossman is the CEO and President Emeritus of the Rome Foundation, President of Drossman Center of Education and the Practice of Biopsychosocial Care. He is also Professor Emeritus of Medicine and Psychiatry at the University of North Carolina at Chapel Hill. He is founder of the Rome Foundation and is an internationally recognized scientist, clinician, and educator in DGBI and communication skills training. He is a pioneer in researching the impact of trauma and abuse in patients with IBS, with the first NIH-funded study in the area. He is passionate about engaging and educating his patients to utilize self-management techniques in their recovery. Today, Dr. Drossman is joined by our Rome Foundation board member, Maura Corsetti. Dr. Corsetti is Associate Professor Gastroenterology at the University of Nottingham in the UK. She has dedicated her entire life to the study of role of motility and the pathophysiology of functional bowel disorders, and in particular to study the mechanism of action of drugs to treat constipation. I now turn things over to the esteemed Dr. Drossman.
Thank you. Hey, Maura. With those introductions, Maura, we'll have to talk quick.
Yes, it's true. It's true.
Anyway, thank you. It's good to have you, Maura. We've, for those out there, we've known each other only a few years, and you've been on the board, the Rome Foundation board, for maybe a year and a half now.
Yes, yes.
So I'm getting to know you more, and I certainly know about your work. For those of you who don't know, Maura is also the co-chair of the bowel committee for Rome 5. And if you don't know about Rome 5, I'm not sure why you're on this webinar. But Rome 5 will be coming out in May of 2026, and that will set the stage for our guidelines in all the bowel disorders, which brings us to this topic, which is IBS, specifically IBS with constipation. So again, welcome. Glad you're here.
Thank you very much. And yes, it's my pleasure to be here and to discuss this topic, because it's a very relevant topic. And IBS is one of the most frequent DGBI, disorder of the gut-brain interaction. And I'm particularly interested in the subtype of constipation because it's one of the most difficult one to treat, I think, in clinical practice. And I think that patient will be really interested in understanding a little bit more about this.
That's great. So why don't we begin? And I think the first thing is really to understand the subcategorization. We have IBS-C, IBS-D, IBS-M, even IBS-U. So tell me what IBS-C is relative to the other components of IBS.
Yes, so well, let's start saying that what is IBS? IBS, as I said, is very frequent, so 10% of the general population suffer from this disorder. And as you said, there are different subtypes. The subtype with constipation is where the patient presents with abdominal pain, that is a key feature for all the subtype of IBS, but in particular, this is associated with an alteration in the bowel habits in the direction of constipation. That means that the patient can present with difficult to pass the stools, straining, hard stools, infrequent bowel movement together with the abdominal pain. And it's very important to understand that to have IBS, the patient really needs to have these two aspects present. So the abdominal pain and the altered bowel habit, and the two of them needs to be related to each other in this way. So normally what we ask in clinical practice is that we say, well, you have this pain. Is this pain normally getting worse when you are more constipated, or is this pain getting better when you finally open the bowel? And if the answer is yes, indeed, we found a relation between these two characteristics that are really specific for irritable bowel syndrome, and in this case, with the constipation subtype.
But how does that compare to chronic constipation?
Well, good question. Well, there are still some debate in the field, because we know that chronic constipation present with the same symptom of constipation that a patient with irritable bowel syndrome and constipation have normally. But the difference is that the abdominal pain is an important feature, so it's combined with the constipation, while in the chronic constipation, normally the patient has less abdominal pain and probably present more discomfort or pain only when it's many days that is not able to open the bowel. So in this way, you kind of differentiate the two conditions, even though we know that there is probably a continuum between the two, and so people can also, well, migrate from one to the other.
Right, and I think that's important because as we understand chronic constipation and IBS-C, we're dealing with different targets for treatment. So what you might use for chronic constipation, you might not use for IBC. Maybe you could tell us a little bit about what the medications are for treating IBS-C.
So
constipation.
So I think that is very important that to really underline the fact that when you are in presence of a patient with irritable bowel syndrome with constipation, this means that you have two symptoms that basically you need to deal with. One is the abdominal pain and the other one is the constipation. And sometimes the medication that we have available can make better one of the two, but not necessarily also the other one. So it's very important to decide which kind of treatment we want to propose to our patient, but also to make sure that the patient understand to which kind of the symptoms we are directing our treatment, so that in case that the patient come back and say, well, for example, if we prescribe a laxative and the patient come back and say, yes, my constipation is getting better, but I'm still in pain, this is not actually a surprise, because this means that probably we need to add something else to deal with the pain. And normally, in my clinical practice, I start asking the patient what is the most bothersome symptoms for them to start really dealing with that symptoms. And if they say that this is constipation, then I have in mind different possibilities, starting from laxatives. And here we have laxatives that are just osmotic. In a way, they just make our stools in the bowel a little bit more soft, and this normally travel easily in the bowel. Or we can have also stimulant laxative, and in that case, the stimulant laxative can really stimulate a bit our large bowel to improve the way that we open the bowel. Even though we need to take in mind that in patients with irritable bowel syndrome and constipation, can happen that with stimulant laxative, for example, yes, the patient get better with constipation, but the pain can get worse. So it's difficult sometimes to find a balance between treating the constipation and not making worse the pain. And this is something that I normally discuss very well with my patient to make sure that he understands that we need to find that balance, and can take some time to find the right medication in each person to really reach this point. Of course, we have also medication. We are lucky in this field that we have medication that has been developed and really found to be effective to treat both constipation and abdominal pain in patients with irritable bowel syndrome and constipation. And I'm thinking about medication like the secretagogue, like linaclotide, for example, that is a medication that has been demonstrated to treat both. But once again, can also be that the patient come back and say, well, yes, this is helping, but not completely with my abdominal pain. And then in that case, you can combine with something else.
What are the mechanisms of actions of, say, the secretagogues or some of the other agents?
So, for the when I told you before about the laxative, we have the osmotic laxative that are called like this because normally these are kind of medical device, let's say, that attract the water inside our bowel, and so they make the stool more soft. This is the principle of the osmotic laxative, for example. Then for the stimulant laxative, we know, for example, that there are different classes of there, but for example, bisacodyl or picosulfate, they are actually acting, increasing the motility of the large bowel, so stimulating the contractions of the bowel, but together with also increasing the secretion of the bowel. So they have a double effect, and this is why they are helping with the constipation. But as I said, they are more targeting the constipation. For the abdominal pain, when I describe the possibility of linaclotide, this is a drug that has been demonstrated to increase the secretion inside our bowel, but has also some evidence that can act on one of the alteration of irritable bowel syndrome, the one that is more frequent in this patient, that is the visceral hypersensitivity. So it's making the sensitivity of the bowel less hypersensitive. So in this way, the bowel is sensing less the sensation, and this makes, for example, the abdominal pain less of a problem with this medication. And the beauty of linaclotide is that this is combined with an effect also on the constipation, and the two of them, this medication can treat both these symptoms. We have also then, of course, in patients that improve with constipation but are still having problem with their pain, we have other options to add as a medication, and we have what we consider the first line treatment, let's say, for pain, that are antispasmodics. So these are medications that are supposed to really relax, let's say, our bowel, and so because sometimes are really the spasm and the contraction of the bowel that make the pain worse, with this medication we are really reducing this hypercontractility. Otherwise, we have medication that now, well, we use quite widely, and I have to say that, of course, in my clinical practice, because I work in an hospital, in a secondary care hospital, where normally I see probably the most severe patient with irritable bowel syndrome, sometimes we need to use some other medication, and we use neuromodulators. And these are very interesting medication because are medication that have been used for different reasons, but in this field, they have been demonstrated to be really effective in treating abdominal pain in irritable bowel syndrome. And we have even very recent study confirming this data, and they act really on regulating exactly this brain-gut interaction, and in some way rebalancing the dysfunction of this gut-brain interaction. And these are medications like, for example, amitriptyline or nortriptyline that are really useful to be used in a patient with where the pain is one of the main complaint of the patient.
When do you decide someone with IBS-C to add a neuromodulator? Is that routine, or are you looking for some signals?
So normally when I see the patient for the first time, I normally go through all the medication that he or she has tried before. And of course, in my clinical practice, it happens frequently that they come and they've tried already antispasmodics, and they tried already the first kind of line of treatment. And then in that case, I normally decide that, I discuss with the patient the different option, because we have also non-pharmacological option. We need to discuss the role of the diet, lifestyle modification. But if the patient has tried all of this, normally then I propose the neuromodulators. And I explain very well, because of course, unfortunately, at the moment, this medication is still in the leaflet the description that they are antidepressant. And so some people think that we are using this just because we think that IBS is a psychological disorder, which is not. And so I explain to them exactly the mechanism of action and the fact that they act on the visceral hypersensitivity. And normally, if you take time and you explain to the patient exactly what they are doing, they normally are fine with trying this medication. It's very important to explain to the patient that these medications are not acting fast, so they can take 1 month, 1.5 months before start working properly. And normally in my clinical practice, I start with a low dosage that in UK, the lowest dosage of amitriptyline that we have is 10 milligram, for example, but I even start with half of the tablet for 10-20 days, and then I ask the patient to increase the dosage, and then I normally organize a follow-up in 2 months' time to make sure that the patient has tolerated the medication, that has continued the medication, and then decide whether we need an adjustment of the dosage, keeping in mind that in most of the cases, we don't need to go high with the dosage. In most of the cases, up to 50 milligram, the patient is normally responding to the medication.
I think your point's well taken about explaining to the patient the mechanism, because if they understand that this is dysregulation of the brain-gut axis and neuromodulators normalize it, and that's why we call them neuromodulators, not antidepressants,
Yeah.
it gets them away from the dualistic model that, well, are you thinking it's a psychiatric problem?
Yeah.
Let me ask you something else. Let's say you put someone on linaclotide. They have a lot of abdominal bloating and they don't go very often. Stool is hard. And then all of a sudden they're getting diarrhea. What does that mean and what do you do about it?
Well, can be that, well, we know that one of the side effects of linaclotide is that it can be to act a little bit more than expected. So normally this is something that happens at the very beginning of the treatment. Is not so frequent that then with time this is happening, but can be that this is happening either because, well, one of the possibilities is that the patient is actually a patient that is alternating between constipation and diarrhea, and actually maybe is not really an IBS with constipation, or can be that at a certain moment the patient, the bowel of the patient is improving, and we need to just probably reduce the frequency of the intake of linaclotide. This is what I would do on a first place, rather than, because normally they need to take this every day before breakfast. We can try to reduce also the frequency. I don't know if this is what you had in mind with this question, or whether you had something else that you wanted to.
Yeah, well, I think that is, of course, it's a side effect and you have to watch for that. But if you have someone and you take an X-ray and they have stool all out there throughout their colon, and you put them on linaclotide and they get diarrhea, what's happening?
Yeah. Well, this can be also what we call the overflow diarrhea, because indeed is not really a true diarrhea, is because they are kind of impacted by the stool, and then this is what happens normally, that they have this expulsion of liquid stools, but in reality they are impacted. So normally the diagnosis is made, is enough to have a digital internal examination rather than really doing an X-ray, but of course, if you are in doubt or if you want to have the confirmation, this is something that we can do. Definitely, yes.
Okay. Well, that's really, I think, the point, that overflow diarrhea should also be considered. Do you make any distinction between, I know, for example, prucalopride is not indicated for IBS, but it does help constipation. Do you ever go off label and do things and combine medications? How do you do that?
Yeah, I do this. So normally I have to say that when they come, and of course they have tried the first line, I try with linaclotide, but suppose that linaclotide is not effective or is not enough. Sometimes, of course, I consider to combine or even switch to medication like prucalopride, that, as you said, is not really licensed for IBS with constipation, but I found this very useful. And the way that I use this in patients with irritable bowel syndrome, because I have in mind that indeed the bowel is more sensitive, is that while in functional constipation or in chronic constipation, I normally start with 2 milligram. In patient with irritable bowel syndrome, I start with the lowest dosage, that is 1 milligram, and then I see whether the patient is tolerating the medication and whether he's seeing any improvement. And if this is the case, then it's enough. Otherwise, I will increase to 2 milligram. And this is in general something that now I'm doing quite regularly with any medication with irritable bowel syndrome, because, for example, we were used to prescribe a stimulant laxative like bisacodyl immediately with 2 tablets, because this is what has been found to be effective in clinical trials. But now we realize that probably in some people this is too much, and it's better to start with the lowest dosage and then explain to the patient that they can increase rather than really giving a high dosage, and then the patient has the side effects, is afraid of trying again the medication, and then we are in trouble. So this is something that I change in my practice over the years, because I realize that it's better to start low and then maybe increase, and explain exactly what what is the reason of this to the patient. Yes.
Yeah, that's a good point. I mean, I've had some patients who took 3 or 4 Biscodal, which kind of
Yeah.
blows them out, and they get very frightened about that, and they don't ever want to
Yeah.
take it again.
Yeah. And I think that this is an important, and once again, I don't stress enough, I think, the fact that sometimes as a clinician, we are really busy and we don't take enough time to really explain to the patient the mechanism of the medication. And if we explain what they are supposed to do and what they need to expect from this, normally the patient really understand and is able to help us also to find out the better solution, because sometimes if you don't explain, the patient go home thinking that the medication is for abdominal pain. They get frustrated because the abdominal pain is not improving, and then yes, this is a vicious circle that starts, and we have really then an unhappy patient, and then also an unhappy clinician, I think.
Very good. Thank you. You know, one thing we skipped over, which I think is important for the providers and also for the patients, is constipation is very common. There can be a lot of other things that could cause it.
Yeah.
How do you make the diagnosis of IBS-C?
Yeah, so normally the diagnosis of IBS is a diagnosis that is based on symptoms. So as I said before, the symptoms are characteristics, and if you collect a good clinical history, normally this is enough to make a diagnosis. Of course, you need to exclude few conditions, and there are very few investigations that you need to run in your patient to make what we call a positive diagnosis, because it's not correct to really run a lot of investigation that we know from the beginning are not going to be useful. And these few investigations, that the one that I normally run, are of course some blood tests to make sure that the patient is not anemic, that there is no increase in the inflammatory markers. And what I normally check, and I do in all my patients, is to check for celiac disease, because celiac disease is more prevalent in patients with irritable bowel syndrome, and normally this is something that I routinely do in my patient. And I also check for the thyroid function, even though I know that the data are not really suggesting that we should be doing this routinely in every patient, but it's something that I check. And then of course it depends also from the age of the patient and the family history, because of course if you have a patient that has a family history of bowel cancer, or is a patient that comes at your attention and has more than 50 years old, depending on what are the guidelines in your country, you might consider that this needs to be investigated to exclude a cancer that in any case is not the first thing that I will think in a patient with irritable bowel syndrome with constipation, because there are a lot of studies demonstrating that constipation is not, patients with constipation are not at higher risk of cancer as compared to the general population. So this is not something that I will really have as a first things in my mind. But these are the conditions that definitely you need to exclude.
What about in your experience? How often do you see patients who you diagnose as IBS-C? They come back 6 months later and they've got IBS-D. Is this a common thing, and what do you do about that?
Yes, this happens. Of course, you need to first exclude that they are not really taking medication that change the bowel habit in one direction or in another. But yes, it can be that well, sometimes they present in one way and then they come back 6 months later and you realize that this is a patient that alternate between diarrhea and constipation. This is a tricky patient as well because of course what I normally do is that I try to target more the abdominal pain, and I try to see whether sorting out the pain, we also improve the bowel habit. Just for example, it's possible that just providing and prescribing amitriptyline, you make better the pain, but also the bowel habit. And normally I try not to treat either constipation or diarrhea because you end up, of course, making worse the other situation. So normally I try to explain to the patient that there is this alternation and that sometimes they don't need to be afraid because, for example, they are not opening the bowel for a few days and then they have diarrhea. It's just how the bowel presents. But of course, if the patient insists, normally you can also ask what is the most prevalent alteration of the bowel, and then you target that in a way that you take in account that, of course, this is not a patient, for example, with just diarrhea that then you can treat with medication for diarrhea. You need to be careful because sometimes just a little dosage of anti-diarrhea medication makes this patient constipated. So it's really a balance that you need to find. And in most of the cases, I use, for example, the neuromodulators because in my experience, they are helpful and they regularize, they normalize also the bowel habit.
And I think also for many of the patients, pain is the dominant feature. It's what
Yeah.
brings them to the doctor, and maybe they can
Yeah.
tolerate some irregularity of the bowel if the pain is
Yeah.
better. Many of them
And
sitting
I
on.
don't know if you and I don't know if you use, but in my patient I use frequently, especially in the alternating one, also the rectal irrigation. So it's something that I don't know how popular is in USA, but here in Europe we use in this patient because sometimes, of course, rectal irrigation is something that we use both for constipation and also for incontinence, for example, for fecal incontinence that is frequently present in patients with diarrhea. So sometimes this is something that is useful on top of the neuromodulators rather than using medication. And it's something, they are basically water enemas that are quite useful. And this is something that I use in my clinical practice, but I don't know if this is also in other countries, something that you use.
You said rectal irrigation.
Yeah.
How do
Yeah.
you do that? What do you do?
Basically, the patient received a training from our nurse, and they learn how to do by themselves these water enemas. They are called also transanal irrigation. I don't know if you call this in a different way in USA, but it's something that is very popular in many countries in Europe and also in UK, and it's quite useful because, of course, it's just the principle is that if you put water in the rectum, you distend the rectum really get the signal, give the signal to the proximal part of the bowel to work better. So in this way, for constipation, this is useful. On the other hand, for patient with diarrhea or fecal incontinence, the water is really emptying the rectum in the proper way, and this can be useful also in people that have this feeling of incomplete evacuation that is frequently associated with irritable bowel syndrome. So it's something that I found really useful.
We do something like that we usually will put them on a regimen. Let's say we have them on linaclotide, maybe also on prucalopride. And if they haven't gone in 3 days, we have them take an enema. So I think it's really the same thing. We're looking at it as a rescue. It's like bisacodyl after 3 or 4 days.
Yeah,
Okay.
it's the same principle. Yes.
The other thing we do, and I don't know how often you do it in the UK or Europe, is when we have patients who are having a rough time and they do have a backup of a lot of stool, we do a colonic flush, just like a prep for a colonoscopy to kind of empty the bowel and reset things. And then they tend to do better on the medication.
Yeah, this is not something that we do, at least in UK, so frequently. I know that is done more in children, but I think that we have some cases where the patient, for example, is admitted where this is done. But I think is another well important suggestion in difficult situation, because they can happen, unfortunately. Yes.
Well, thank you. This has been very informative, enjoyable. Any last
Also for
words,
me.
anything you'd like to tell the audience? Any key points you'd like to make, or are we through?
Well, I think that once again, I want just to remember the clinician and the patient that irritable bowel syndrome is very frequent. That they are not alone. There are a lot of patients that suffer from this, and we have a lot of things that they can use and that we can give to them to help and to improve their quality of life. And they need just to really make sure that they see the right clinician that is expert in this kind of condition, because we can make their journey better, I think. And this is a hope for them, because sometimes people comes to us a bit hopeless because they run with different clinicians, and we are here to help, I think.
Thanks for those final words. Tanya, anything else?
No, it's been very informative, and I really like the question where you brought up, do you often see patients with IBS-C go over to IBS-D? And yes, and I've run into that, and I've had friends run into that. So I think that's a good discussion around that, going over that. So thank you so much
Yes.
for your expertise today.
Thank you. It was a pleasure.
Take care. Bye.
Bye-bye.
Bye.